So, this is oral cavity pathology. We have three categories of oral cavity pathology that we are going to discuss. The three categories of oral cavity pathology include inflammatory conditions, proliferative conditions, and conditions associated with salivary glands. We are going to address three conditions among the inflammatory ones: aphthous, HSV, and candidal conditions. For aphthous conditions, you need to bear in mind just 2 points. One is the associations with aphthous lesions, which are IBD, celiac disease, and Behçet's disease, and the morphology that has a rim of erythema. For HSV inflammatory conditions of oral cavity, you should remember that it is mostly HSV1, yes, but because of the new sexual practices, HSV2 is becoming also a common cause of HSV pathology in the oral cavity. Then we have the primary versus secondary HSV infection. The primary HSV infection is most commonly seen in children at ages 2 to 4 years as asymptomatic infection, not as the second type of primary HSV1 infection, which is gingivostomatitis. The secondary or reactivation of HSV1 infection has its important associations, which are trauma, allergies, ultraviolet light exposure, upper respiratory tract infection, pregnancy or menstruation, immunosuppression, and exposure to extreme of temperatures. The important morphologic features of HSV infection include ballooning, formation of intracytoplasmic or intranuclear eosinophilic inclusions, and giant cell formation. Then we have finally the third category, which are the candidal associated infections. When it comes to candidal infection, we have to bear in mind a couple points. One is the severity or depth of the inflammation is associated with the severity of underlying immunosuppression. There are 4 types of immunosuppressive conditions that are most commonly associated with candidal infections, and they are neutropenia, chemotherapeutic treatment, transplantation, and HIV/AIDS. 2 other conditions than the severity of immunosuppression include the strain of Candida, most commonly albicans strain, and the changes in normal flora, most commonly due to antibiotic use. The morphologic features associated with candidal infection especially include the underlying erythema and the fact that the lesions are scrapable. Second category of the oral cavity lesions are the proliferative lesions. Fibrous lesions, leukoplakia, erythroplakia, and squamous cell carcinoma belong to the proliferative lesions. What are the fibrous proliferative lesions of oral cavity? They include fibromas and pyogenic granuloma. What's important about fibroma, you should remember that fibromas of the oral cavity are submucosal nodules seen alongside the bite lines. The second important point is the pyogenic granuloma, the second important entity of proliferative fibrous lesions of oral cavity. What is a pyogenic granuloma? It's a vascular, pedunculated, ulcerative gingival mass. In what groups it's seen? In children, young adults, or pregnant women. And what are the possible outcomes of pyogenic granuloma? It can regress, it can form fibrous mass, or it can form ossifying fibromas. What are the important morphologic features of the pyogenic granulomas? They resemble granulation tissue, as their name indicates, because they include vessel or vascular proliferation. Second group of proliferative lesions of oral cavity include leukoplakia and erythroplakia. Couple points about leukoplakia. It's most commonly seen in smoker males at ages 40 to 70. It is a diagnosis of rule out, and most important feature of the morphology of any form of leukoplakia, inclusive of hairy leukoplakia, is that they have hyperkeratosis, acanthosis, ballooning at stratum spinosum, and they are not scrapable, as was the case of candidal infection. What are important associations of hairy oral leukoplakia? They are caused by Epstein-Barr virus. 80% of the cases of hairy oral leukoplakia is seen in AIDS patients. What you need to commit to memory regarding erythroplakia: erythroplakia are the lesions that have higher risk of malignant transformation than leukoplakias, and They have a velvety, depressed appearance. Finally, neoplastic lesions of oral cavity. We are going to begin with the squamous cell carcinoma. There are a couple points about squamous cell carcinoma. One is small tumors have higher survival, however, they have also higher chance of second primary tumor formation. What is the theory that explains this? The theory of field cancerization. It just simply explains that multiple primary tumors of squamous cell carcinoma in oral cavity are due to independent of primary tumors. What are the two common pathways of squamous cell carcinoma of oral cavity? One is associated with chronic alcohol and tobacco use, and the second is associated with oncogenic HPV, especially HPV 16. What are the carcinogens associated with tobacco pathway? One is mutations that are induced in TP53, and the other are the direct carcinogens carried by tobacco smoke, including P63 and Notch1. What are the pathway associated with pathogenesis of oncogenic HPV16? It's overexpression of P16, which is a CDK inhibitor. What is the important feature of the squamous cell carcinoma? When it is caused by the HPV infection, contrary to the most common forms of squamous cell carcinomas, it tends to occur in the back of the tongue and alongside the tonsils. However, the most common form of SC or squamous cell carcinoma, or SCCs, occur in ventral surface of the tongue and floor of the mouth and lower lips and soft palate and gingiva. What are the histologic features? A morphologic feature is presence of plaque that could be ulcerated. Usually they have pearly appearance like other squamous cell carcinomas, and the big larger sizes could be associated with ulceration, and underneath the plaque we could have leukoplakia or erythroplakia. The histologic features are not associated with biologic behavior. Histologic features could be well differentiated, which means white, which means keratinized squamous cell carcinoma, or anaplastic. However, these are not associated with the behavior. Differentiation degree is not associated with biologic behavior. Finally, the tumors we are going to ask or discuss are the salivary gland tumors. They include the benign pleomorphic adenoma and malignant mucoepidermoid carcinoma. So let's focus now on the pleomorphic adenoma. You should remember that it's most common in parotid gland. It has morphologically 3 components, and that's probably why it's called pleomorphic. One are ductal, the other are myepithelial, and the other are matrix components. One important other point about the pleomorphic adenoma is the fact that surgical resection should include safe margin or tumor-free margin and not just shelled out for the resection of the tumor, because high rate of recurrence and in rare cases malignant transformation on top of it could occur. Finally, mucoepidermoid carcinoma, 2 points to remember. Similar to the benign pleomorphic adenoma, it's also more common in parotid gland. Second point is the smaller the size of the tumor, the higher the chance of malignancy. Contrary to the squamous cell carcinomas that we mentioned, the smaller tumors have higher survival rate. And what is the morphologic appearance? It could include sheets or cords of squamous or mucous cells or intermediate cells, and mucous cells are mucin positive in histological staining. Thank you. This finishes our oral cavity pathology.